Hi everyone, me again. So today we're going to be talking about diabetes. We're going to talk about the different types, the risk factors, signs and symptoms, and the treatments. I'm a student at Middlesex Community College. This is intended for my own studying purposes, and if any of my fellow students want it to help them, don't take anything that I say against me. Please correct me or add anything if I forget. We'll help each other learn. So I'm going to talk about type 1 diabetes first. And so type 1 diabetes is going to be about 5 to 10% of all cases. It's obviously significantly lower than the amount of people who have type 2 diabetes. So what happens in type 1 is you have destruction of the beta cells of the pancreas, and these are responsible for the production of insulin. And so it's going to be a very quick stop of this production of insulin versus, type 2. It's going to be progressive. And so these patients are typically pediatric, but it can happen to anybody at any time in their life, but it is usually seen in the pediatric population or anyone under 40. And so these patients are going to present usually to the emergency department upon diagnosis. They're going to have unexplained weight loss. They're going to have polyuria, polydipsia, and polyphagia, and fatigued. And so to just kind of explain why are they having these signs and symptoms. So if they have sugar in their body but no insulin to transport it across the cell membrane into the cell for the body to use, then they don't have energy. And so that's going to give us fatigue. They're going to have a buildup of sugar in their blood but not in their cells. And so if our blood is full of sugar, we're going to try to technically drain ourselves from all the sugar, right? We're going to drink a lot and we're going to pee a lot. And so that's kind of us trying to, a defense mechanism, trying to flush our system and rid us of all that sugar. The unexpected weight loss and polyphagia. So why are we eating a lot and still losing weight, right? And so when you have hyperglycemia and type 1 diabetes, these patients are not getting, sugar into their cells because they have no insulin to do that. And so their liver is going to start doing glucogenesis. And so what it does is it produces enzymes that break down the fat and muscle. And so this is going to break down the fat and muscle of your body, causing the weight loss, but then it actually just in turns increases your sugar more because even though they're breaking down this adipose tissue and this muscle, there's still nothing we can do with that sugar because we don't have the insulin. The insulin is a problem. It is an autoimmune disease, and sometimes you can see antibodies in patients who have type 1 diabetes. You have an increased risk factor if you're of European descent. And the only way to treat these patients is to give them outside or exogenous, I can't pronounce anything, insulin outside. Their body cannot produce insulin. We need to give it to them for the rest of their life. They can get this insulin via injection or pump. There's pros and cons with both of them. So an injection you would try to do at least twice daily, but it should be done upon waking up, going to sleep, before and after meals times. It's less complicated for patients who don't really want to manage it or are poor at managing their diabetes. So it's less complicated and easier to manage, but also does not promise you a tight glycemic control. Versus a pump, which does give you a very tight glycemic control, but they can be expensive, the fear of it having a malfunction, and because it's placed in your skin to obviously read your skin and deliver this insulin, you can have skin issues for that. We also have type 2 diabetes now, and so this is usually happening in the older patients, and so it's 80 to 90% of all cases are in the adult population. Even though insulin is present and it is being produced by the pancreas, we do not have enough. And so these patients usually present with, poor diets. They eat a lot of processed food, fast food, high sugar, they drink a lot of soda and things like that. They don't work out. They have a sedentary lifestyle. Maybe they smoke. Maybe they have contributing metabolic syndrome. And so those are people who are shaped like the apple and people who have just hypertension, which is 140/90 for blood pressure. Those are all contributing factors. And so what happens is they basically have beta cell failure. And so remember, we need insulin to help push sugar across the cellular membrane. And so patients with type 2 diabetes, their pancreas gets tired with keeping up with the amount of insulin. And so these people are eating lots of sugar, right? And so their pancreas is constantly pushing out insulin to regulate their blood sugar. And so after some time, their cells can become two things. It can be insulin resistant. And so that's when it takes multiple insulin molecules per sugar molecule to push it into the cell. And so now you're using up more insulin per sugar. You're still going to end up with more sugar left over because your pancreas just can't produce the amount of insulin to keep up with the necessary demands the body needs per sugar to go into each cell. And then also, so yeah, those are the two. The body can't produce enough insulin. Over time, the pancreas gets tired, and the fact that the cellular membrane is resistant to the insulin and it takes more of it. And so the signs and symptoms of somebody who has type 2 diabetes is going to be visual changes. They're going to see cotton wool spots, which are like mini blood vessel breakages in the eye. Usually someone who doesn't know they have type 2 diabetes, it can be diagnosed by your ophthalmologist. You're going to have neuropathy, numbness, tingling, poor wound healing, recurrent vaginal infections, fatigue, sexual changes, and you can have any one of these symptoms that are classic for type 1 because, again, you have a lot of sugar in your blood, so you're going to flush yourself out and those type of things. The risk factors, like we talked about, having metabolic syndrome, having a low HDL under 50, having a BMI, body mass index, greater than 30, or having high triglycerides greater than 150. And so those are all indicative of just unhealthy, overweight lifestyle, being inactive, sedentary. And so our treatment is going to be focused on education, glycemic control, and nutrition and exercise. So these patients are producing insulin, right? It might not be enough, and that's why they're having the hyperglycemia and the issues, but they are producing it. And so we don't need to give them outside insulin right away. We want to talk to them and try to fix the problem at the source. And so we're going to educate them that they can take oral medication to help the pancreas or to slow down the metabolism of the starches, or we can talk to them about glycemic control, doing a carb counting plan, doing nutrition and exercise. So they should be doing 150 minutes a week of exercise. We want to tell them that if they lose 7% of their body weight, that would really lower their chances. And 30% of these patients with type 2 diabetes are eventually going to need outside insulin, just like the people in type 1 would always 100% need. And so a lot of the contributing factors to why someone might end up on outside insulin and not really take care of themselves. Depression is the major factor, non-adherence. The other two types of diabetes are going to be pre-diabetes, and this is when blood glucose levels are higher than normal, but not high enough to be considered diabetes. This is when you're really like advocating and educating the patient. They need to lose 7% of their body weight. They need to eat healthier, work out, that they, they're pre-diabetes. You don't have it yet, but we really need to fix a lot of things so you don't get it. And so we also have gestational diabetes, which is diagnosed about 24 to 28 weeks. It's when you do a glucose drink. If you test positive, you have the chances of having a macrosomia baby, which is 10 pounds or more. Usually these patients' blood sugars return to normal 6 weeks after delivery, but within the next 5 to 10 years, they are at an increased risk of developing hyperglycemia, diabetes type 2. And you really want to educate them that because they're at risk, they should be eating a healthy diet and maintaining an active lifestyle to decrease the risks of that happening. Types of diagnostic management. So how are we going to monitor ourselves if we have one of these diagnoses, whether it being type 1 or type 2. And so you can do self-monitoring, and this is when you do a finger stick to yourself. It's a real-time blood reading via finger stick. You want to educate your patient to rotate fingers. You want to stick them on the side of the finger rather than in the middle of the pad. You want to wipe away the first drop of blood. You want to check your sugar at a minimum before meals and at bedtime. You want to try to maybe document what your sugars were, what your foods were, and that way you can kind of make trends for yourself and try to keep a tight glycemic control as best as possible. One of the biggest issues or errors with this is an inadequate blood sample from the patient. So really teaching them and having them demonstrate back to you the proper way to get a blood sugar is very important for these patients. For a random blood sugar, anything less than 200 is technically okay. And for a fasting blood sugar, it should be under 100. Between 100 to 126 is going to be indicative of pre-diabetes, and anything higher than 126 in a fasting blood sugar is going to be indicative of diabetes. We never diagnose a patient off of one reading. We're going to need multiple readings and multiple random sticks or whatever the hospital, doctors are prescribing. But that's what it's indicative of. That doesn't mean we're diagnosing the patient with it off of one blood sugar reading. We can also do continuous glucose monitoring. And so this is when a tiny sensor is inserted under the skin. It can stay there for 7 to 10 days at a time before needing to be replaced. It reads your blood sugar through your interstitial fluid. This is really helpful because it saves data and can make trends for you and see what's working, what's not working. You can also set alarm or alerts, and so this way you can, if you're an avid runner, right, if there's things starts beeping and you're getting an alert to your phone, oh man, I should have, eaten a snack since I took my insulin before going for this run, things like that. And so it helps you stay alert if any dangerous levels are approaching and keeping those boundaries. Of course, with technology, anything can malfunction, and so always checking your pumps, checking your self-monitoring, making sure it's really, make sure your Bluetooth's connected to your phone, make sure it's, on and working, there's no recalls, all things like that are important. And then we have a hemoglobin A1C, and so this basically shows how glucose has been on the red blood cell, how saturated a red blood cell is with glucose in the last 3 months. And so if you think about it, red blood cells usually live for 90 to 120 days. So this is perfect, and it gives us a really good visualization of how this patient is handling their diagnoses and if they are having a tight glycemic control under it. And so if it is anything under 5.7, we're happy. That is great. Not indicative of diabetes. Anything 5.7 to 6.4, that's going to be pre-diabetic. And then anything above 6.5, we're going to label as diabetes. One thing to note about this, if you are a patient who is super poorly managed, and some days you have very high highs and some days you have very low lows, it will balance out and read as a normal result when you get your A1C drawn. And so that's something for providers to look out for and see the patient's documentation where they've seen in the hospital for high blood sugar and then low blood sugar, and then kind of put 2 and 2 together. Another thing to make known about this is that it's over 3 months, and so if you just exercise and fast the day before, or you fix yourself a week before getting it, it's not that, none of that is going to make a difference in your result. It's over a 3-month period, and you're going to want to get 2 done a year, and then every 3 months if you're not hitting your target goal. And so you and your provider are going to come up with whatever your goal is, and if you're not hitting that, you're going to get it done every 3 months. If you're hitting your goals and maintaining them, you're going to get it twice a year. Insulin therapy, and so we want insulin to mimic the pancreas. And so you're going to have a basal and a bolus, and so basal is going to be before meals or rapid and / short, and then a bolus is going to be long-acting or intermittent. And so instructions for insulin, we never want to heat or freeze it. We want to keep it at room temp for 4 weeks while it's in use. Any extra insulin should be refrigerated. If you're prescribed Lantus, after 28 days, it will be expired. You should not have it in sunlight, and always double check that you have U100 or U500, depending on whatever insulin you're prescribed, because that can be a deadly mistake. You want to inject it in your arms, belly, butt, and thighs, and you're going to inject it at a 45 to 90 degree angle, depending on how much adipose tissue this patient has. Determines your angle, so the skinnier, the lower the number, the 45, the chunkier, then we would go 90. It's going to be sub-Q. We always want to rotate sites to avoid lipohypertrophy, and so these are kind of just like little pockets full of fat. And so insulin pens are available for elderly people who could have vision or dexterity issues. The pump is, an insulin pump is gold standard. It best mimics the pancreas, and it gives you freedom, discretion. You don't constantly have to carry so many needles around with you, and it gives you a tight glycemic control, and you can get alerts on your phone. So now we're going to talk about possible complications that can occur with someone who has diabetes. And so we have diabetic ketoacidosis. And so this is when you have type 1 diabetes usually. It can happen in type 2, but most always it's type 1. And so this is when there is an inadequate insulin production to push glucose into the cells, and you have a rapid breakdown of fat stores. So a really helpful nurse at my hospital gave me this awesome idea, and he explained it as if you have a house in the winter and you have a fireplace there, right? And you have a match, right? So the match is going to be the sugar, right? But you don't have any wood. The wood would be insulin. And so you have the match, lots of matches in this house. You have all this sugar, but you have no wood to burn it on. You have no insulin to do anything with. Your house is not getting heated. Technically, the patient is not getting sugar into their cell. And so what do? You do the next best thing. You start burning down your house. You set your furniture on fire. And so that's what technically is happening in DKA. You're taking your fat storages. You're taking things inside of you and using that as fuel. This ends up just increasing your sugar more because you're still not having the insulin to push it into the cell. Now insulin builds up. And so these patients are going to have ketones in their urine. That's a hallmark factor of DKA, ketones in the urine, and that's just showing the breakdown of fat. And so with ketones in their urine, if you were to draw their blood, they're going to have a low pH, anything under 7.3, and that's going to be indicative of metabolic acidosis. They're going to present to the emergency room typically within a couple hours because their symptoms are so severe, so fast. They come to the emergency room very quickly, and they're going to have the 3 Ps again: polyuria, polyphagia, polydipsia. They're going to be fatigued. You're going to notice Kussmaul respirations, which are going to be rapid and deep, and they're going to have a fruity breath smell. These patients will have projectile vomiting from the buildup, and so we're going to be drawing labs, and their blood sugars are going to be high, not crazy high, right? Because they've only been in this for a couple hours. So, probably around the 400s, anything over 250 per the book Hoffman. And so these patients are going to be having dehydration and electrolyte imbalances because they're, drinking so much, urinating so much, pushing the sugar out. They're also pushing their electrolytes out. And so they're going to present with a high heart rate, maybe a low blood pressure due to these fluid imbalances. Hypokalemia and hyponatremia are going to happen, and these are the 2 electrolytes. So whenever a patient is having DKA, hypokalemia happens. And so you've diagnosed the patient, you've come in, you've smelled their breath, you've noticed their respirations. We just, dipped a urine and saw it has ketones in it. The patient has a high blood sugar. And so what are our nursing priorities? And so they are going to first get an IV of normal saline. Second, they're going to get the insulin therapy. And it's going to be when blood sugar reaches 250 from fluid therapy, drive 5% dextrose. I don't know what that means. Ignore that. So we're going to first do normal saline, and then we're going to do insulin therapy, and then we're going to do a potassium replacement. And so these are all basically, like Professor Small said, happening simultaneously. You're having 8 providers in this room helping you. Everybody's hanging everything. But if you just think that you're going to be giving the insulin IV, then the IV needs to happen first. So IV happening, you're hanging the fluids. Now we're going to give insulin. But now that they have the med and the fluids are hanging and running, we're going to give the potassium replacement supplement. And that differs from a different condition called HHS, or hyperosmolar hyperglycemic state. And so these patients are typically hyperglycemic also. They can be up in the thousands, 800s. And so they're having significant dehydration, and they're not going to have the ketoacidosis aspect to it. And so to better explain it, these patients now, they're in the house. They have a match, and they only have 2 pieces of wood. And so, they're in a house, they have a match, and they have so much wood, right? But they only have 1 match for it. And so they're burning their logs with that 1 match. It runs out, but they have, 10 wood left over. And the same thing happens day after day for the next week. So this truck keeps bringing them wood, and wood's piling up in their house, but they don't have enough matches to light it. And so this is the same thing if you think about it. And so these patients, they have so much sugar, so much wood, but they only have so much insulin, which would be the match, to put it into the cells. And so they're metabolizing some of it, and they're able to, kind of go on their everyday life. Nobody's really noticing these crazy symptoms in them that are bringing them to the emergency room right away, like DKA. But they're having a slow buildup of sugar in their body, like the person's having a slow buildup of wood that they can't do anything with because they only have so many matches. And so these patients are going to have severe hyperglycemia around the 600s. It's going to be profound. They're going to have profound dehydration because this has gone on for, it can go on up to a week. And so typically you're going to find these in patients who have type 2 diabetes, who are over the age of 60. Usually there is a issue that happens prior. So an example would be a patient who has an infection, and say maybe their liver isn't producing enough insulin because of the infection, and so they should have gotten outside insulin to make up for it during the time being. And so this happens that they have a buildup of sugar because they don't have enough insulin from their pancreas. That could be a reason why this is happening. Over the next couple of days, these patients are going to have neurological symptoms that are getting progressively worse, altered mental. And when you dip their urine or take their blood, they're going to have serum osmolality of higher than 320 or high urine osmolality, and that's going to be it's super concentrated with these electrolytes, and that's why they're having severe dehydration. And these patients are also going to be treated with a large IV bolus therapy, right? We need to get fluids into them. They may or may not need insulin depending on what the precursing factor is, if they just need to be, flushed out. And then obviously too, they are going to be getting a replacement of potassium or whatever it is that they need. And so another complication is going to be hypoglycemia. And so that is when there is not enough sugar for the amount of insulin in the blood. And so this is going to be anyone who has a blood sugar less than 70. They're going to present irritable, anxious, diaphoretic, headache, blurred vision, confused speech. Those are all going to be, early signs of it. Late signs are going to be seizures, coma. Definitely these patients are a safety precaution. They can fall. They shouldn't be behind the wheel driving. They can be very reckless. They're confused. They can be combative. So one thing to watch out for patients who have hypoglycemia is a thing called autonomic neuropathy. And so they might not feel any of the warning signs. So typically patients who are young and well managed, when they, aren't if they missed a meal or if they took too much insulin accidentally, whatever the case may be, they can feel these signs and symptoms. They can feel themselves getting shaky. They can feel themselves sweating more, not feeling well, and they know, let me check my blood sugar, let me correct this. These patients don't have the warning signs anymore, not even their liver. And so their liver is not doing the glycogenesis and getting sugar through, breakdown of adipose tissue. It's not doing that. They're not even noticing. Their body is like numb to the fact essentially that their sugar is dropping until it's, too late. And so it's really important that the people around them know what the signs and symptoms are if they're not able to recognize it in themselves and get help. If you were to find a patient whose sugar was less than 70 and they were able to swallow, you're going to want to do the rule of 15s. And so you're going to give them about 15 grams of a carb. We want to avoid carbs with fat, such as like chocolate or ice cream or things like that, because fat does take longer to digest than a simple carb. And the purpose of this is to really just get their sugar up as quickly as possible. And so we're going to repeat this 2 to 3 times until the sugar is above 70 or if the patient is unable to swallow anymore. If they're unable to swallow, we can do 2 things. If we have IV access, we're going to be giving them D50. And if we have IM access, if we can't get IV access, then we're going to have to go IM and give them 1 milligram of glucagon. If we're either one, we're going to have to give the patient an actual meal afterwards. I've seen in my own experience patients who, came in with a sugar of 19. We got an IV going. We gave them the D50, and their sugar shot up to almost the 400s. We gave them a lot of sugar, and you'd rather have a high sugar that drops back down and that you can correct and stabilize than a patient who has no sugar, right? And so we want to make sure they have a meal to actually do something with all the sugar and have a carb to go to it. And so they don't have the rebound hypoglycemia. If you did give a patient the IM injection of glucagon, you need to turn them on their left-hand side because that has a adverse effect of nausea and vomiting, and you wouldn't want the patient to aspirate. Things to look out for hypoglycemia are especially in the alcoholic or ETOH population, college students who maybe have type 1, and so the influx of sugar through the alcoholic beverage shoots you up, and then if you don't have a meal or anything to stabilize it, then you drop down low, and it can sometimes be confusing to tell if your friend's drunk or if they're having a hypoglycemic episode. And so having the people around you be educated on what your diagnoses are and making sure that you take care of yourself and eat a meal before drinking to sustain yourself are really important. Another complication is going to be hyperglycemia, and so this can cause macrovascular changes, which consist of changes in the large arteries that supply the brain and heart, and these arteries become damaged and narrowed, and it increases your risk of MI and stroke. I believe the book says 4 out of 5 patients with diabetes end up dying of cardiac MIs, cardiac issues. We also have microvascular changes, and so we talked about this, that the eyes are going to have cotton wool spots, and these are going to be the kind of mini breakout hemorrhages, and the patient is going to be diagnosed with diabetic retinopathy. It is the leading cause of blindness in adults, and it is mostly diagnosed by an ophthalmologist. Their gums are going to be early tooth loss and periodontal disease. If you think about your saliva, it holds a lot of sugar in it, and so that's kind of, if you have hyperglycemia, just sugar everywhere in your body essentially, and sugar is just going to decay your tooth. And our kidneys, it is the leading cause of renal failure. You're going to want to always check these patients' BUN, creatinine, and GFR. GFR should be, I believe it's above 70. Anything under 70 is indicative of not well. BUN is 5 to 15. I don't remember these. And creatinine I know is 0.6 to 1.2. The kidneys will also shrink in size as well, and you're going to have a leakage of protein in the urine. That is, really indicative of kidney disease. The patient will also experience diabetic neuropathy. So it's going to be a loss of sensation, pain that increases at night, paresthesias, and it can be accompanied with PVD or peripheral vascular disease and poor circulation. And so these patients who are having the pain diabetic peripheral neuropathy, we're going to be wanting to give them gabapentin. It is an anti-seizure med, but it can help with the nerve pain, essentially. And so these patients have peripheral vascular disease, and so that's many occlusions in the small blood vessels. And, for your feet example, diabetic foot care is so important. So we're going to just kind of use that as our example. And so if parts of the feet are having these, many occlusions where the blood vessels are getting so narrow from having the high blood sugar that they don't have a good blood flow, it's not getting good oxygenation there. Plus, put on top of that they have the loss of sensation in these outer extremities, which are usually your hands and feet. And so these people, they get an injury on their foot. It could be the smallest little nick, and they don't know that they had it. And it never heals because they have the peripheral vascular disease where oxygen's not getting to that area. They don't have, the regular inflammatory response to heal it. And so if they're not checking their feet and they're unaware of it, their foot can be completely necrotic and they not even feel it. And so I think that is so important, diabetic foot care. And so things that you want to educate your patient on is the number one thing is to wear shoes that fit you properly and that are properly broken in. You want to check the shoe for pebbles, rocks, little things like that. You want to wash your feet every day. You want to refrain from soaking them, more of just cleaning them, inspecting them, looking at them. You want to lotion your feet to make sure they don't get cracked or cut. The biggest thing you want to do, you want to, wash in between your toes, but between your toes need to remain dry. Do not lotion in between them. When you wash in between them, it doesn't matter what you do, between your toes remain dry. That is number one for them. They also can be set up with podiatry, and so you don't want to cut your own toenails and risk, injuring yourself, bleeding, infection, anything like that. So you can get your foot care done at a podiatry office and limit the amount of infections or issues with that. And then, so if they did have a cut for any of these obvious reasons and it went unnoticed, they had the poor wound healing or recurrent infection, something that the body couldn't, no matter the amount of antibiotics and care given to it, the body just couldn't fight it off, we're going to amputate it. Diabetics are the most, I think it was 15 to 45% more likely to get an amputation than any other person for any other reason. And so I think that is just so important, just as their nurse, to educate them, look at their feet themselves, and things like that. Two other last complications that stood out to me were the Somogyi effect and the Dawn phenomenon. And so the Somogyi effect is less common. And so it's basically when you receive too much insulin before bed and your body releases cortisol as a fight or flight mechanism, and your sugars then rise above normal. When you wake up in the morning, you'll have hyperglycemia. And Dawn phenomenon is going to be the release of cortisol and growth hormone by the body during the early hours of dawn. You did not give yourself enough insulin before bed. So these naturally occurring sugar surge while you're sleeping causes you to also wake up with hyperglycemia. And so because you're waking up in the morning with hyperglycemia with both, how are you going to determine which one you have, right? And so you're going to have to wake up between the hours. The book says 2 to 3. Professor Small said 3 to 4. Basically, we're going to call it 3, hours of dawn, and to see what your body is doing. And so if you take your blood sugar and it's low, then you automatically know that you're having the Somogyi effect, right? That your body ends up compensating and going up high. That's why you're waking up with hyperglycemia. And if your sugar is either normal or high, then you're going to know it's the Dawn phenomenon because you either already had the surge of hormones overnight and that brought your sugar up already, or it's going to be normal because you haven't had that surge and your body is just normal with the amount of insulin that you took. And so how are we going to treat it? And so if you woke up with the Somogyi effect and you're having low blood sugar at 3 a.m., you should just eat a snack, right? Because you took too much insulin. So eat a snack, fix it. And if you have the dawn phenomenon and you're waking up and your sugar's super high at 3 in the morning because, the release of cortisol and growth hormones, what should you do? Probably give yourself more insulin to bring that sugar down. Obviously, you don't want to be eating a snack at 3 in the morning and giving yourself insulin at 3 in the morning every single day. And so what you should be doing after that is adjusting your dose long term so you don't run into that complication. We talked about patients who have type 2 diabetes who end up taking medications to help them manage the signs and symptoms of it, so they don't need outside insulin. And so they work on increasing insulin production, stopping insulin resistance, and decreasing hepatic glucose production. And so the first group we're going to have the sulfonylureas, and me, Michaela, and Hannah kind of made little slogans with these, so I'm just going to share them. So our aunt Bonnie Rhea, has 2 twin daughters. Their names are Glip and Glime, and they say wah all day long. And so it's going to be W for weight gain, A for alcohol causes flushing, don't drink alcohol on this, H for hypoglycemia, H for hypersensitivity, and H for hepatotoxicity. And our aunt, Sulfuria, she promotes the release of insulin from the pancreas. We have the biguanides, which is metformin. And we know from Professor Small's PowerPoint, if you're on metformin, you need to stop it 24 to 48 hours before CAT scan because it kind of interacts with the kidneys, with the dye, and so that needs to be discontinued. You want to use caution in any patient who has a renal impairment or suffers from lactic acidosis in the past. That is a issue, and it may cause diarrhea or other GI upset, and this is a decreased glucose production from the liver is how this helps out. We have the metglutinides, and so the metglutinides, we think of a girl named Nate who's at a pageant, and it's Nate glutinide and repaglutinide, so that's where we get the PAG pageant. And so Megan and Nate are at a pageant, and so they didn't eat before going on show, and so they're feeling super nervous. They're not feeling well, shaky, and so the biggest thing for this is that the beta cells are producing more insulin also. So if you're having insulin and you're not having that followed by a meal, what are you at risk for? Hypoglycemia. And so you should be eating a meal within 30 minutes of taking this, and if you are skipping a meal, you shouldn't be taking it. We have the glucosidase inhibitor, and that is Miguelito and Acarbose. That's how I pronounce them, and I think that Miguelito is Acarbose, and his car has a slow breakdown while he's having GI symptoms, and he's like rushing home. He's trying to rush home, go to the bathroom, but his car is slowly breaking down. And so the way we rationale that is Acarbose and Miguelito, or however you say it, is a slow breakdown and absorption of sugar and carbs. Signs and symptoms are going to be upset stomach, flatulence, diarrhea. And so you should be taking this medication with the first bite of each one of your meals. First bite of each meal, take one. And then we have thiazolone. Don't even make me pronounce this one. So it's basically just Thea. We're going to stay there. It's that med. And we have pioglitazone and rosiglitazone. And I think what we came up with was going to be like aliens live in the glitazone. So Pia and Rosie live in the glitazone. It takes them 3 to 4 months to get there because it takes this medication 3 to 4 months to work. It is not safe for anybody who has fluid retention, such as heart failure, because it causes headache and weight gain. Not safe for anyone with liver hepatotoxicity, and it improves insulin sensitivity. It is most effective if you take those if taken with people with insulin resistance, and it decreases glucose production in the liver. And the next two, I'm not studying because we never learned about them in pharmacology. So for the purposes of my video, for my studying, I'm not going to talk about them. Lastly, we have the types of insulin, and this is going to be anything that someone on type 1 with type 1 diabetes takes, or someone who has type 2 diabetes who needs outside insulin now because their pancreas is so damaged. And so we have rapid acting, and that's going to be Lispro, Aspart, and Glucosamine. And I think rapid, and the acronym for Lispro, Aspart, Glucosamine is LAG. And so it helps me remember which ones go to which. So rapid, lag, they're opposites. So that helps me. Its onset is within 15 to 30 minutes. And so I know that this patient is going to have a hypoglycemic episode if their food is not already ready in front of them to eat. And so if it's not, I'm not giving it to them. We have short acting, which is going to be regular insulin. It's going to be Humulin R, Novolin R. Its onset is going to be 30 minutes to an hour. And so these kind of patients, I would make sure that they order their food. I know it's coming up, right? The cafeteria called. They're going to be on their way in 10 minutes with the food, things like that. It doesn't need to be right there with them because it doesn't peak until, it doesn't have an onset until an hour to 30 minutes to an hour. And so as long as the food is ordered, then I feel okay with it. And then we have intermediate acting in that NPH. And so this is going to be Humulin H and Novolin H, and then it's going to cover the need for half the day or overnight. You're able to mix this medication, and so you would draw up regular before NPH, clear always before cloudy. I believe, someone correct me if I'm wrong, that short acting is the only one you can give IV. And so the last one is going to be long acting, and this is going to be Lantus, Glargine, and Detromere. And I think it's detrimental that you take this once a day at the same time every day, and it's used to just mimic your pancreas at the constant bolus rate that you would be getting to maintain you for the day. And basal insulin. And that's all she wrote. That's all I have. Let me know if anyone wants to add anything to it or correct anything that I said. I am not a diabetes specialist. Thank you.